Mr. Chairman, dear professor and colleague, this is a case, as Dr. Sopri presented, a STEMI patient with multi-vessel disease. Actually, this is a 74 years old female. She has a history of only hypertension, not diabetic. She had severe chest pain since 1 hour. She presented with a blood pressure of 110/75 and heart rate is 55, although she was not in cardiogenic shock. Her ECG showed infralateral STEMI with highly elevated cardiac enzymes, normal kidney function, and the echo showed a lateral wall hypokinesia with an ejection fraction of 58, preserved systolic function. This is the angiogram. As we can see, there is a tight mid-LCX lesion just before the bifurcation, followed by totally recently occluded circumflex artery. Her LED again is showing a calcified proximal stent and mid-tight lesion at bifurcation with a big diagonal branch. And we can start seeing also that her right coronary is not free of disease, as we can anticipate some retrograde flow from the left system to the distal circumflex. Again, this is the LED lesion at bifurcation with the diagonal, but with good distal flow in the LED. And this is her right coronary artery showing ostial calcific tight lesion, followed by a proximal calcific lesion and another mid-significant lesion, and a competitive flow from the retrograde collaterals filling from the left system. So we are having a mid-LCX followed by a bifurcation lesion in the OM. We have ostial proximal and mid-calcific lesion in the RCA, and we have a long mid-calcific lesion in the LED at bifurcation with a diagonal in a patient with inferior and lateral ST elevation myocardial infarction. So this patient has a double bifurcation lead and diagonal, double LCX bifurcation and OM and RCA lesion. She is old age, either to do the whole procedure same time or stage. What about the calcification? What about the use of antiplatelet in this low body weight fragile female with 74 years of age? What will be the choice of antiplatelet? So the panel, please, what will be your decision for this case?
شيف انا معلش ليا تعليقين على السؤال حضرتك. السؤال الاولاني you have to wait in the case of STEMI the results of the lab and to do echo before to go with the patient to the primary PCR.
In our hospital, we have the cardiac enzymes which appear within 15 minutes. We have a special kit for high sensitive troponin. We have the results less than.
I didn't ask about the troponin. You result renal function and
urea creatinine. Even usually we have the yes. Yeah. No, we don't have to wait. We already track the patient is pulled
down. You doesn't recommend to wait for echo and before.
No. Echo is screening in the ER. We have an echo machine in the ER. Immediately, just echo screening routinely while the other personnel are preparing the patient.
Second question, in diagnostic case for STEMI, you have to take all these views. You did about 9 projection.
I was not sure which is the culprit, because we have a circumflex and as well as I anticipated a retrograde flow in the RCA, and she is having infralateral STEMI. So
it is clear that the RCA is the culprit because there is
actually the circumflex was the culprit.
Dr. Khaled, I would like to comment on this important point. You said, do we have to take several views in a case of STEMI? Yes. You have to spend a couple of minutes to take several views to make sure that you are not missing part of the angiogram. Because some of us doing angiogram in a hurry and take the whole time to do the calculate vessel and ignore some important information. And after that, you have to devise the angiogram again and again and again. So in 2 minutes, it doesn't.
لا مش مسألة minutes. هي مسألة إن هم حوالي
7 views.
داي دي اسكيميا. انت بتحقن داي في عيان زي ما انت بتقول عنده ليفت سايد اسكيميا ورايت سايد اسكيميا، وانت بتحقن داي هي جزء، فانت السسبيلتي اللي يحصل في اف او يحصل ريست اثناء المالتيبل Morocco, do you think in case of STEMI, with this, with slow filling the side and about subtotal occlusion of the RCA, multiple injections in such cases, do you recommend this scenario?
But I think here, in the case, the definitely is most probably not the LAD. So the question is the circumflex or the RCA? Sometimes it's very difficult. In some situations, I still recommend an old-fashioned VGRAM. You do 11 trichrogram acutely, 20 cc of dye, and immediately you have the idea which is the culprit area. I think we forget this, but this is an additional tool sometimes helpful. In the case you presented, I would, if there is an ST elevation in the inferior lead, I would go after the RCA.
Inferior and lateral, yes.
Yeah, but most probably this is a situation where you have to do both vessels. But it depends what the ECG change after you have treated one vessel. And, but if you have difficulties to open the RCA, I will not spend much time and go to the left.
My impression, I saw the Andrew's very quickly, was that the distal circumflex looked like it was acutely totally occluded,
Yes.
which I would, for simplification, for lateral infarction, and a patent RCA, I would think this is probably the culprit lesion, circumflex. I can't see the double bifurcation. I can't see a bifurcation of tooth marshal at all. I don't even see a stenosis there. So I don't know what you mean by double bifurcation. The LAD is a non-issue in this situation. And I would, I hope you were agree, because you're a lady, this lady, the way you described her, she's bleeding time bomb, low body weight, elderly, bad kidneys. So probably grading is a good idea. I would just go for the circumflex, probably after 2 or 3 views, maybe not 9, but just a few. And then see how things go. Most probably not do the right at the same time. See how it's fitting. Because as Professor Colombo mentioned, if you do the circumflex and everything's fine, you don't really want any slow flow or refill. But I would probably do the right during index hospitalization, a day or 2 later. And FFR the LA.
Let me pose a very simple point, and I would like Sherif to comment on this. Do you routinely, when you do a STEMI case, start with a diagnostic catheter, or you directly go to a writing catheter?
No, diagnostic, yes.
You always start with diagnostic?
Yes.
For example, do you always start with diagnostic catheter when you do STEMI case?
No, absolutely. I use diagnostic catheter less and less.
Yes.
But it's staying almost there.
Yes, exactly. So when you know that you are dealing with a STEMI patient, there is no need to waste your time using diagnostic catheter. Just go with driving and you do your view. If you take the first, if you are a case like this with probably the right the culprit, and you take the first initial view of the left, and you look, things look almost not significant. Would you keep doing all the Andrew views, or just take one or two views and take to the culprit?
One or two views, of course, make sure that I'm not missing anything, but not.
You do the minimum. You don't do the maximum views, and just do the minimum. Because
but make sure that I don't jump. Always take a little bit of time to think.
true, yeah.
Because 10
But at
minutes
least
is okay.
there are 2 points here that I think we can agree on you, Dr. Colombo, that we don't have to use diagnostic catheters routinely in STEMI patients. You might use the driving right away, and you don't take all the standard views when things look very clear that there is nothing major in the left system inside the go. And you can go back to
perhaps have any kind of invitation.
Thank you for your invitation. Well, in this case, I think I would look for the bridging collateral on the right, because if there is a collateralization of the right coronary from the left, and furthermore there are bridging collateral within the lesion of the right, then it's very probable that this is an older lesion. So we'll go straight for the obtuse marginal and circumflex, which appear being the caput lesion in this case.
Good point. But in this patient, it was, I think there was no difficulty with apparently this was a chronic lesion and something acute happened to the right coronary, because there was some unilateral flow from the left.
This is a very important point. The message that we need to deliver, we need to do using more guiding catheter in STEMI rather than diagnostic catheter, as Dr. Colombo said. I think not all the operator or arterial problem. I think we still need to do a very good diagnostic procedure even in STEMI. This will check the anatomy of the coronary arteries, the difficulties. Because if I go with the guiding catheter, a very odd anatomy and a very difficult writing of the changing, you will take more time, and the more expenses to use guiding catheter while you cannot use the diagnostic catheter for the right coronary. I think on the guidelines must go with diagnostic catheter for every patient, and then this will.
I think the problem is, as a trainer, for me, I'm telling you, I'm doing diagnostic catheter to the left and right, even after I know inferior artery. But I will take only few views, like Khaled said. This is the idea number one. Number two, to say it's collateral. Number three, to see what's the best guiding catheter. Sometimes you can use guiding XT4, sometimes you can use left ampullus, because you get it by diagnostic left ampullus. Don't spend time with the guiding for the cost and for the heavy.
Let me make a couple of comments, Dr. Colombo. I want to second what Dr. Colombo said. As elevation MRI, yes, you are racing with time, but racing with time does not mean you have to overlook the ABCs of what we do in the CAT. We always must get enough images to know what we want to do. This is one. The other thing, when you do radial CAT, for me, I've been doing this radial for almost 10 years dedication. I use for all STEMI patients a guide catheter, like what Dr. Colombo said, a radial dedicated guide catheter in the hands of people who do that a lot, 8, 9 times of 10. You can actually view both of the coronaries very easily and with very, very minimal time. So I would actually stress those points. And Dr. Colombo mentioned something very important. When you identify the contact, we've been overlooking the value of doing an angiogram in the cath. You can do an angiogram, and that will tell you where the culprit is sometimes. You know, looking at the regional wall motion at the moment. Thank you very much.
So the second time, can you show us what you have done and then you continue?
Okay, I agreed that the circumflex, I felt it was a cultured lesion. As I anticipated, it had a recent thrombotic occlusion. Actually, the patient, she had a right mastectomy due to cancer breast, so I didn't feel comfortable to go through the right radial, and I didn't go for the left, so I went for the femoral approach, although the risk of bleeding is high. And the patient, we started with circumflex procedure. We started with balloon dilatation with no thrombus aspiration, balloon dilatation several times, but still we didn't have a good distal flow in this distal circumflex due to the high thrombus burden. We had intracoronary injection of nitroglycerin and verapamine and a bigger balloon starting to have good flow in the distal circumflex. Then we started stenting of the mid circumflex in the area of culprit occlusion. And after that, we tackled the proximal to mid LED lesion with another stent, which was deployed at a high atmosphere. And this is the final result after 2 stents in the circumflex. After stenting of the circumflex, the patient was off pain and her chest pain resolved. We had a pot dilatation. several times, and this was her final picture after doing the circumflex. I told the patient that we have other lesions. I was planning to do only the right coronary and the LED, which for my decision was a tight lesion, a significant lesion in the mid LED. And I told her that we are going to do it in another session a few days later. She was a very decisive person, and she told me that she will not go into a cath lab again. Whatever you want to do in my coronaries, just finish it today. So I went for the LED after I finished the circumflex. I had the several balloon dilatation. Then I stented the mid circumflex with a long stent, followed by another stent in the circumflex, which only took about 10 to 15 minutes and less than 30 milli of contrast media. And this was the final picture of finishing the LED. And finally, we also tackled the right coronary artery. We had our guiding caster, and we had the guide wire, again, balloon pre-dilatation of the proximal and mid parts of the right coronary several times, then stenting of the proximal and mid RCA lesion, followed by stenting of the proximal RCA, ostial RCA, and flaring of the ostium. This is a balloon post-dilatation and dilatation between the two stents, and this was the final angiography for the right coronary artery. So we had this circumflex before and after, and this was the final result for the circumflex artery with two stents. This was the mid-LED, tight long lesion, and this is the final for the LED. And this was the RCA, and this is the final picture for the right coronary. So total contrast used in this patient, although the multiple view, because we have only 4 milli of contrast injection during each projection. And total procedure time, it took about 2 hours since the patient went into the cath lab. We chose to use clopidogrel for the risk of bleeding with aspirin to reduce the risk of bleeding, and especially when we are using the femoral approach. Total hospital stay for the patient was 3 days, 2 days in the CCU and 1 day in the normal room in the ward. And thank you.
Very nice piece, Sherif. Excellent job. I just have some philosophical questions. I'd like Dr. Colombo's input on it. Some people use long stents, whereas some people advocate short stents. Now, obviously, there has been marked improvement in the technology of stents, and the problems we have with restenosis, with longer stents and bare metal stents, they have much higher restenosis. It's decreased with the new technology of drug-eluting stents. But how do you feel about putting longer stents versus if you can get away with just shorter stents?
This is a very complex question. It's really very difficult to answer. I philosophically prefer short stents, but young people prefer long stents. I stopped going into this debate. But I like short stents. It's more difficult, you take more responsibilities. If you have to go to the office or you have to go to important dinner, you go for long stays. But if you, in my view, if you want, I prefer short stays. But I don't want to make a rule. That's my view.
Okay. As a Dr. Hamid, I would like to comment on this case.
No, this case is a success.
I want to have
The main problem is the referrals of the patient. In many cases, we need to do post-patient file. On the table when you ask the
Dear
patient,
doctor, your time is up.
if you can complete the procedure with no complication,